Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Welcome to the Going Antiviral podcast. Today, March 3rd, 2024, we are at the Conference on Retroviruses and Opportunistic Infections, otherwise known as CROI, and we are speaking to Dr. Jean-Michel Molina, professor of infectious diseases at the University of Paris in Paris, France. Jean-Michel, welcome to the show.
Thank you very much for your invitation.
It's great to have you here. You are one of the innovators, I would say, of approaches to clinical care, thinking outside the box. You were instrumental in putting forward PrEP as the so-called 2-1-1 approach that has been very successful. And then more recently, this whole notion of reducing other STIs by using Doxycycline as post-exposure prophylaxis. And a recent study you had about 2 years ago where you were studying doxycycline as post-exposure, but you had linked in that same study the use of a meningococcal vaccine to reduce Neisseria gonorrhea, and of course both are of the Neisseria species. And so the thought was that this might help the DoxyPEP work. And so when you're using DoxyPEP, that was pristine and that sort of came through. But there were some issues with the study going into the summer of 2022. Maybe we can just kick off there, and I'm not trying to put you on the spot, but there are, I think, some lessons learned in that experience that you had.
No, you're perfectly right. I think, the reason why we were interested in reducing STIs among people using PrEP is because we've seen such high rates of STI among these people. And since PrEP is so effective, whether you take it daily or on demand, people actually didn't care anymore about HIV because they were not anymore afraid of catching HIV, but they were concerned about STIs. And so we said, well, there is something we have to do to help them reducing these STIs infections. And that's why we first tested Doxycycline, a very cheap and old antibiotic that has retains strong activity against most STIs. And so we said, well, let's test whether Doxy, given as a post-exposure prophylaxis to avoid, too much antibiotic pressure, whether it could reduce STI rates. And actually it did much better than we thought. And, these data have been confirmed now with a recent US study. And actually at this conference, we will present the final analysis of our study, confirming that for chlamydia and syphilis, with DoxyPEP, you reduce STI rates by roughly 80%. Less so for gonorrhea, but still there was a 30% reduction, probably because gonorrhea is already resistant to tetracycline in many parts of the world. So with these prophylaxis, you may not be able to prevent infection with the bug, which is already quite resistant. And that's why we wanted to test another strategy to prevent gonorrhea, because we knew Doxy would not be so effective. And we said, well, there is a vaccine for another Neisseria, meningo B, and actually there have been a number of retrospective studies and cohort studies suggesting that when you give this vaccine, you would reduce gonorrhea and not chlamydia infection. But these were, all these studies were retrospective, and so we said we need a prospective trial to see whether this vaccine would prevent gonorrhea, because there are antigens that are very similar between Neisseria gonorrhea and Neisseria meningitidis. And so that's why we conducted this trial. We started the trial before COVID, so we were actually stuck by the COVID pandemic, and then the monkeypox outbreak, and then by issues that we were not expecting when we did our interim analysis. Because the study actually was in the summer of 2022 prematurely discontinued by the DSMB based on the results of an interim analysis showing that not only Doxy was effective, but also the vaccine on the primary endpoint, which was the time to a first gonorrhea infection. But actually, when I gave the presentation at CROI last year about these results, I felt a bit uncomfortable because the secondary endpoint, which was the cumulative infection of gonorrhea, was not significant with the vaccine. It was almost significant, but not so. So there was a reduction of cumulative rate of infection, but not significantly so.
So let's, for some folks who aren't as familiar with clinical trials, a Data Safety Monitoring Board is an independent group who oversees the conduct of the trial and also looks at results as they come in, make sure that accrual is going well and that there's no harm being done to participants. And an interim analysis, which you referred to in the summer of 2022, is a predetermined time where data is collected, a freeze on the data happens, the statisticians come in and evaluate the results so far, and they see whether there's any futility, and that could be in either direction. It could be that the intervention's not working at all and there's equality between a control group and your intervention, and they'll stop the study prematurely because it's just no sense in going on, or they could recommend stopping the study because of efficacy, and that's kind of what happened in your situation, right?
Exactly, and the reason why the DSMB triggered this interim analysis was because at the same time, at the AIDS conference in Montreal in the summer of 2022, the US team actually released the results of the DoxyPEP trial in the US, showing that Doxy was actually very effective in reducing STI rates. So that was the second trial following the one we did in 2018, showing that indeed Doxy would reduce STI rates. So then the DSMB felt that we may not need, it would be important to see whether in our ongoing trial similar results would be obtained, in which case there would be no reason to continue the study between those receiving DoxyPEP and those receiving no DoxyPEP.
So for them to do this analysis, they have to collect the data as it exists so far, and that assumes that the endpoints have been collected completely and have been reported dutifully, and they make that assumption, then they do an analysis and give you the outcome. So you're picking up where you left off. You said you came to CROI last year, 2023, presented the data, a little uncomfortable because the full endpoint wasn't completely statistically different in the vaccine group. The Doxy group, no problem, right?
Right, no problem with Doxy because the difference was striking between the arms. Regarding the vaccine, for the primary endpoint, there was a reduction by 50% of the risk of a first gonorrhea event. When you looked at the cumulative events, the difference was not statistically significant. There was a strong trend, but it was not statistically significant. But that was the first time we've seen an effect with this vaccine in prospective studies. So we thought, well, this is interesting, and that's why the DSMB said, well, you've got your endpoint. You may stop the trial and provide the participants the option to receive, all of them, the vaccine. And so that's what we did. I mean, the interim analysis was released to the DSMB. The DSMB made that recommendation. And usually you follow the DSMB recommendation. It's difficult to go against a DSMB recommendation. So we looked at the data as well, and the data looked pretty good for the first endpoint, primary endpoint. Secondary endpoint, not so great. And in retrospect, what you would say, it's not always sufficient to have, a success in your primary endpoint. You probably want to make sure that all secondary endpoints are very supportive as well. So, that's what happened. And
so you leave Seattle, you go back home, and then what happened?
Well, then we said, because the interim analysis was based on the data collected until July, because the DSMB met early September. And so we said, well, now we will ask everyone to come back for the last visit, because visits were scheduled every 3 months, to see whether we want to receive Doxy and or the vaccine. So then we were in September. The last patient's last visit was in February of 2023. So that was just before CROI, actually, of last year. And then by the time you do the monitoring, collect the data, then we were waiting for the final analysis with all the data collected. So no longer the interim analysis, but the final analysis with 5 more months of follow-up. So potentially with more events accumulated during that time, because there was no emergency to give the vaccine or doxy immediately to all individuals, because it was not like a threatening infection. It was not like HIV. Most of these STI were asymptomatic. So we said, well, let's wait for the participant to come back to their next scheduled visit to let them make the choice of receiving the vaccine or doxy, right? So then the monitoring was completed, and the analysis was done with the final data. And then, so the statistical team and the clinical trial unit came to us and presented the data and said, well, and I was a bit anxious about the data because, well, you never know what could happen between the interim analysis and the final analysis. And so the results on doxy were exactly similar, although you had accumulated more events. But to our surprise, regarding the effectiveness of the vaccine, there was no longer statistical significance for the primary endpoint. And although there was a trend, the trend was no longer significant with a p-value of 0.06. And it's usually when it's below 0.05 that you could say that this is not by chance that there is a benefit. So not only was the difference no longer significant, but the hazard ratio was actually lower because the initial effectiveness was in the range of 50%, and the final result, which I will present tomorrow at CROI, was only 20% difference.
Which isn't that different at all. So just on a personal note, you've already presented this, your name's out there with the study, you gave a result, and you're sitting in this presentation by the statisticians on the final data. How did you feel?
Well, I would say I was not that surprised because I feared that the result would not be similar for the final analysis. So I was anxious to get the final results in order to actually wrote the paper was almost already written. I was just waiting for the final data to put in the paper to submit it. So I was obviously shocked, and I wanted to understand what happened. More importantly, because at that point when I first looked at the final data, I wasn't sure which one was right. Was it the interim analysis or the final analysis? And I said, well, there is something wrong. We have to understand where is the mistake. And so we looked at, again, I wanted to look at all the events, all the data from the interim analysis and the final analysis to make sure that they didn't make a mistake at the statistician in the statistician unit. And then what I realized is that the number of events that have been accumulated between the interim analysis and the final analysis was too high just to be, collected for, more months of follow-up and more individuals. It was too high. So there was something missing. And after like 3 days of intense investigation with the work with the clinical trial unit, well, they finally acknowledged that for the interim analysis, they just omitted a file to put in the interim analysis. And so the interim analysis was not wrong, but it was based on a small number of events, not all the events that have been collected at that time.
Incomplete data set.
Incomplete data set, exactly.
So you then enter into a forensic audit of some sort to see exactly what happened.
So then there was suspicion about the entire study. And then we said, well, this is too serious. And so the ANRS, who is the sponsor of the study, and with me, actually, we decided to conduct an audit of the clinical trial unit to understand exactly what happened and to look at the data processing, the statistical analysis. And so an independent group looked at that from start to the study to the end. and repeated the analysis. So the final results we have, I'm pretty confident now that these are the right results. Unfortunately, the vaccine effectiveness, we cannot say for sure that the vaccine has no activity. What we could say is that if it has any activity, it is small and probably not clinically relevant. Because this was for the primary endpoint. If you look at the secondary endpoint, the cumulative rate of gonorrhea, then the incident rate ratio between the vaccine and no vaccine is even lower. It's only 16% difference. So even if you look at the confidence interval of the 16%, you just reached the 30%. That was the minimum rate that we were powered to look at in the trial. So what we could say is that, maybe the vaccine has some effectiveness. If it has effectiveness, it is very low. It's in the range of 15 to 15%, which probably is not good enough for a vaccine to be used, to be rolled over in a population, especially if you prevent, only asymptomatic infections. So I think now this result is based on a large number of events because we have near 250 gonorrhea events in the trial, which is very high. So I think the results are robust and will help to search for additional strategies and other vaccines. And there are actually 2 ongoing trials with the same vaccines against gonorrhea using the meningo-B vaccine, one in the US and Thailand, another one in Australia. So we may also want to wait for the results of these 2 other randomized trials to make sure that our results are consistent in other places of the world. But at the same time, because we discuss also these results extensively with GSK, who is the owner of the vaccine, we had nothing to do with our trial because they didn't even want to give us the vaccine, so we had to purchase the vaccine for the study. That's also why the study was a little bit postponed, because we couldn't get an agreement with GSK, years ago to collaborate on the trial. But they were still very interested by our results. So we had then interesting discussion with them. And because of their results, they actually canceled a large trial that they were about to launch with the meningo-B vaccine.
Got it.
And they have another vaccine that was probably more promising, using the same methodology as the meningo-B vaccine, but instead of using a Neisseria meningitidis strain, they used a Neisseria gonorrhea strain with much better, data in vitro, in animal models as well. And this trial has just completed enrollment.
Okay.
So this is a large study, and so there is hope that, eventually we will get there with the vaccine against gonorrhea.
Well, my first reaction is just a tip of the hat to you and your team for the honest assessment. The whole scientific community since COVID has come under attack that the scientists can't be trusted and that they're not honest with their results. And your story is very heartening in the sense that you're paying attention, your team is paying attention. You're always asking the question, I think it came through loud and clear, do these data make sense? Is this adding up? And you had this kind of bothersome feeling in your gut. It's hard to explain, but I sensed what you're saying. And then when that hit you with the actual result, you didn't sort of panic and say, oh my God, my reputation is ruined. Rather, you took the other tack and said, we need to understand what happened here. And you got down to the bottom of it. And I think people respect that. And everybody understands that mistakes can happen, but it's, as long as we're honest and we're constantly assessing what is the truth and we get to it, then I think everybody is going to be very excited to see your presentation at this meeting and for you to have the opportunity to tell the story and set the record straight.
Well, thanks very much. Well, I think what's more important for us and for me actually is to present data that can be trusted. Yes. And I just wanted to make sure when I publish a paper or when I do a study that the results are real and are good and that I feel good with the results. And these are data that can be useful for others. And, and even more for the patients, actually, of course. So I don't want to mislead anyone. And we are sorry about that, initially we raised hope that the vaccine would be effective. Eventually, I think it is not that effective. It's a shame, but I think we've learned our lesson in this trial. And as I said, then the consequences was that another company like GSK would start their other trial much faster. So rather than spending time to confirm the meningo B vaccine, they were probably convinced by our data, and they said, well, there is no time to waste on this vaccine anymore. Let's try our new potential vaccine, and they launched it. And as I said, they just completed enrollment in this new vaccine, so let's hope
See what it shows.
What it shows.
So we're almost out of time. I don't want to let the moment pass without getting at least your sense of the future. We know that DoxyPEP works. It's being used more and more. I've been prescribing it for quite a few of my patients and seems to be helping them. Doxycycline, it could be the most valuable player among antibiotics. I mean, you think about all the things that it can be used for, rickettsial illnesses and, as you mentioned, chlamydia. How much concern do you have about long-term use of DoxyPEP and potential resistance? We haven't seen the resistance yet, but history tells us that's something to watch.
You're right, and that's my main concern. That's why we are very careful when we released our initial results in 2017, actually. We don't want to push this strategy too far until we would confirm first the results. So now we have, as I said, this US trial, then we have the second trial in France. So it works, at least on the short term. On the short term, we haven't seen any resistance in chlamydia and syphilis. That would be my concern. I'm not that concerned about gonorrhea because the damage has been done already before. With chlamydia and syphilis, we haven't seen yet resistance, at least in humans. But in pigs, we know that chlamydia suis in pigs has become resistant to tetracycline, because pigs were fed with tons of tetracycline and as well as with food from fish who had some genes resistant to tetracycline that were transferred to chlamydia. So I think resistance eventually may occur. We don't know how many years it might take. That's why I think we have to be cautious to use DoxyPEP wisely to really those who need it. And I would say what's important is syphilis. Syphilis is on the rise. We see now more and more congenital syphilis, so that's a shame. So I would say pending a vaccine, this strategy might be used for some months. I would say we have to be quite cautious and not give it to everyone for years. As long as we use it post-exposure prophylaxis, we use a low dose. In our study, people use less than 1 dose per week on average, and that was enough to reduce by 80% the rate of syphilis and chlamydia. So I think a limited use is enough, and we hope that with a limited use, you may defer the selection of resistance by years, because chlamydia and syphilis cannot become quickly resistant like E. coli or gonorrhea.
Let me go to one final question, and that has to do with vaccine for gonorrhea. And my instinct says, after looking at lots of patients, you've seen a lot of patients who've had an episode, several months to a year later, have a second, have a third, and it's like, how much better immunity can you hope for than an actual infection that should be protective? What do we expect a vaccine to do that's more than just exposure to the pathogen and clearance, and then it happens again? So what's your best guess in terms of what we might see with this upcoming result of the gonorrhea, Neisseria gonorrhea vaccine trial?
Right, thank you. I think what's interesting about these studies is that we learn a lot about STIs. STIs have been an area where very little research has been done in the last 20 years. And thanks to PrEP and these people on PrEP that we can monitor for a long time, it's an ideal population to study STIs. And we don't know enough about the natural history of these STI, of gonorrhea. And we have very, sensitive tests like PCR. We can pick up, tiny amounts of DNA from these bugs. And we don't know whether this is mere colonization. Is it infection? Can it go away without antibiotics? And we have studies addressing this issue right now. Do you need really to treat asymptomatic gonorrhea, or do you need to treat only symptomatic cases? What's the potential of transmission when you have only asymptomatic gonorrhea or asymptomatic chlamydia? I think we have a lot to learn here, and the vaccine can, prevent symptomatic disease, maybe not colonization. We know that with meningitis, the vaccine can prevent systemic disease, but not colonization, not all of the vaccine. So the vaccine may prevent severe disease, not colonization. We will see. But again, I think it's fascinating because we are learning a lot. I think a vaccine for syphilis is also something we need. So we are putting the spot on STIs right now, which is nice because we are pushing the research on STI to get the vaccine, and there is no reason we wouldn't have a vaccine for syphilis or gonorrhea, so even chlamydia. So we should continue research in that area.
Well, fabulous conversation, Jean-Michel. Thank you very much for joining us. I think your story gives us a lot of lessons about how clinical trials are done, how they should be done ideally, and I think despite the fact there were some hiccups in the way because of working with an incomplete data set that you had no idea about at the time that the interim analysis was done, the fact that you were paying attention, your team addressed it, I think is a real tribute to the quality of the research that you do, and I wish you all the best for your future studies and these vaccines and other things in the STI world.
Thanks, that's very kind of you, and thank you for this interview today.
Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed in this podcast do not necessarily reflect the opinions of the IAS-USA or its affiliates. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode.